Everyone, welcome to the video lecture for Unit 5, Module 10.1.2. In this one, we're going to be discussing the oral cavity. As always, here are your learning objectives. Please be sure to utilize this when studying for your lecture quiz and the unit exam. So let's continue our exploration of the digestive tract by following the path of ingested food. We begin at the oral cavity, the mouth, or the buccal cavity. The functions of the oral cavity include 1. Sensory analysis of food before swallowing, 2. Mechanical processing through the actions of the teeth, tongue, and platal surfaces, 3. Lubricating by mixing with mucus and saliva, and 4. Limited digestion of carbohydrates and lipids. The oral cavity is lined by the oral mucosa, which has a stratified squamous epithelium. A layer of keratinized cells covers regions exposed to severe abrasions, such as the superior surface of the tongue and the opposing surface of the hard palate, or the part of the roof of the mouth. The epithelial lining of the cheeks, lips, and inferior surface of the tongue is relatively thin and non-keratinized. Nutrients are not absorbed in the oral cavity, but the mucosa inferior to the tongue is thin enough and vascular enough to permit the rapid absorption of lipid-soluble drugs. Nitroglycerin may be administered by this route to treat acute angina pectoris. The mucosae of the cheeks, or the lateral walls of the oral cavity, are supported by pads of fat and the buccinator muscles. Anteriorly, the mucosa of each cheek is continuous with that of the lips, or the labia. The vestibule is the space between the cheeks, or lips, and the teeth. The gingivae, or gums, are ridges of oral mucosa that surround the base of each tooth on the alveolar processes of the maxillary bones and the mandible. In most regions, the gingivae are firmly bound to the periosteum, or the underlying bones. The frenulum of the lower lip is a fold of mucosa that extends from the gingiva to the lower lip, attaching the lip to the gum. The hard and soft palates form the roof of the oral cavity. The tongue dominates its floor. The floor of the mouth inferior to the tongue gets extra support from the glenohynoid and myohyaloid muscles. The palatine processes of the maxillary bones and the horizontal plates of the palatine bones form the hard palate. A prominent central ridge, or raphe, extends along the midline of the hard palate. The mucosa lateral and anterior to the raphe is thick with complex ridges. When your tongue compresses food against the hard palate, these ridges provide traction. The soft palate lies posterior to the hard palate. A thinner and more delicate mucosa covers the posterior margin of the hard palate and extends onto the soft palate. The posterior margin of the soft palate supports the uvula, a dangling process that helps prevent food from entering the pharynx too soon. On either side of the uvula are 2 pairs of muscular pharyngeal arches. The more anterior palaglottal arch extends between the soft palate and the base of the tongue. A curving line that connects the postoglottal arches and the uvula forms the boundaries of the fosses, which are the arched openings between the soft palate and the base of the tongue. The fosses serve as the passageway between the oral cavity and the oral pharynx. The more posterior palolateral pharyngeal arch extends from the soft palate to the pharyngeal wall. A palatine tonsil lies between the palatonsil-glossal and the platopharyngeal arches on either side. The tongue manipulates food inside the mouth and occasionally brings in foods such as ice cream on a cone. The primary functions of the tongue are 1. Mechanical processing by compression, abrasion, and distortion, 2. Manipulation to assist in chewing and to prepare food for swallowing, 3. Sensory analysis by touch, temperature, and taste receptors, and 4. Secretions of mucins and the enzyme lingual lipase. We can divide the tongue into an anterior body, or oral portion, and a posterior root, or pharyngeal portion. The superior surface, or the dorsum, of the body contains a forest of fine projections, the lingual papillae. The thickened epithelium covering each papilla assists the tongue by moving materials. A V-shaped line of valate papillae roughly marks the boundary between the body and the root of the tongue, which is located in the oropharynx. The epithelium covering the inferior surfaces of the tongue is thinner and more delicate than that of the dorsum. Along the inferior midline is the lingual frenulum, which is a thin fold of mucous membrane that connects the body of the tongue to the mucus covering the floor of the oral cavity. Ducts from the 2 pairs of the salivary glands open on either side of the lingual frenulum, which serves to prevent extreme movements of the tongue. However, an overly restrictive lingual frenulum hinders normal eating or speech. Properly diagnosed, this condition, called ankyloglossia, can be corrected surgically. The tongue's epithelium is flushed by the secretions of small glands that extend into the underlying lamina propria. These secretions contain water, mucins, and the enzyme lingual lipase. This enzyme works over a broad pH range, from 3 to 6, enabling it to start lipid digestion immediately. Because lingual lipase tolerates an acid environment, it can continue to break down lipids, specifically triglycerides, for a considerable time after the food reaches the stomach. The tongue contains two groups of skeletal muscles. The large extrinsic tongue muscles perform all gross movements of the tongue. The smaller intrinsic tongue muscles change the shape of the tongue and assist the extrinsic muscles during precise movements, as in speech. Both intrinsic and extrinsic tongue muscles are under the control of the hypoglossal cranial nerves. 3 pairs of salivary glands secrete into the oral cavity. Each pair has a distinctive cellular organization and produces saliva, a mixture of glandular secretions with slightly different properties. 1. The large parotoid salivary gland lies inferior to the zygomatic arch, deep to the skin covering the lateral and posterior surface of the mandible. Each gland has an irregular shape. It extends from the mastoid process of the temporal bone across the outer surface of the masseter muscles. The parotid salivary glands produce a serous secretion containing large amounts of salivary amylase. This enzyme breaks down starches, complex carbohydrates. The secretions of each parotid gland are drained by a parotid duct, which empties into the vestibule at the second upper molar. 2. The sublingual salivary glands are covered by the mucous membrane of the floor of the mouth. These glands produce a mucus secretion that acts as a buffer and lubricant. Numerous sublingual ducts open along either side of the lingual frenulum. 3. The submandibular salivary glands lie along the inner surfaces of the mandible with a depression called the mandibular groove. Cells of the submandibular glands secrete a mixture of buffers, glycoproteins, called mucins, and salivary amylase. The submandibular duct opens into the mouth on either side of the lingual frenulum, immediately posterior to the teeth. The salivary glands produce 1 to 1.5 liters of saliva each day. Saliva is 99.4% water. The remaining 0.6% includes electrolytes, principally sodium chloride and bicarbonate, buffers, glycoproteins, antibodies, enzymes, and waste products. The glycoproteins, called mucins, give saliva its lubricating action. About 70% of saliva comes from the submandibular salivary glands. Another 25% comes from that of the parotid glands, and 5% from the sublingual salivary glands. Saliva continually flushes the oral surfaces, helping to keep them clean. Buffers in saliva keep the pH of your mouth near 7. They prevent the buildup of acids produced by bacteria. In addition, saliva contains antibodies, IgA, and lysozyme. Both help control populations of oral bacteria. A reduction or elimination of salivary secretions caused by radiation, emotional distress, certain drugs, sleep, or other factors triggers a bacterial population explosion. This proliferation rapidly leads to recurring infections and progressive erosion of the teeth and gums. The saliva produced when you eat has a variety of functions, including the following: moistening and lubricating foods in the mouth, dissolving chemicals that can stimulate the taste buds and provide sensory information about the food, beginning the digestion of complex carbohydrates before the food is swallowed. The enzyme involved is salivary amylase, also known as tauin or alpha amylase. Saliva also contains a small amount of lingual lipase secreted by the glands of the tongue. The digestive process begins in the oral cavity, but is not completed there. No absorption of nutrients takes place across the lining of the oral cavity. The autonomic nervous system normally controls salivary secretions. Each salivary gland has parasympathetic and sympathetic innervation. The parasympathetic outflow originates in the salivary nuclei of the medulla oblongata and synapses in the submandibular and otic ganglia. Any object in your mouth can trigger a salivary reflex. It stimulates receptors monitored by the trigeminal nerve, or taste buds innervated by cranial nerves 7, 9, and 10. Parasympathetic stimulation speeds up secretion by all of the salivary glands. As a result, you produce large amounts of saliva. The role of sympathetic innervation is unclear. Evidence suggests that it provokes the secretions of small amounts of very thick saliva. The salivatory nuclei are also influenced by other brainstem nuclei, as well as by the activities of higher centers. For example, chewing with an empty mouth, smelling food, or even thinking about food begins an increase in salivary secretion rates. That is why chewing gum keeps your mouth moist. Irritating stimuli in the esophagus, stomach, or the intestines also speeds up the production of saliva, as does nausea. Increased saliva production in response to an unpleasant stimuli helps reduce the stimulus by dilution, or by rinsing, or by buffering strong acids or bases. Tongue movements are important in passing food across the opposing surfaces, or the occlusal surfaces of the teeth. These surfaces carry out chewing, or mastication, of food. Mastication breaks down the tough connective tissues in meat and plant fibers in vegetables. It also helps saturate the food with salivary secretions and enzymes. The bulk of each tooth consists of a mineralized matrix similar to that of bone. This material, called dentin, differs from bone in that it does not contain cells. Instead, cytoplasmic processes extend into the dentin from the cells into the central pulp cavity and anterior chamber. The pulp cavity receives blood vessels and nerves to the root canal, a narrow tunnel located at the root or base of the tooth. Blood vessels and nerves enter the root canal through an opening called an apical foramen to supply the pulp cavity. The root of each tooth sits in a bony cavity or socket called the tooth socket or an alveolus. Collagen fibers of the periodontal ligament extend from the dentin of the root to the alveolar bone, creating a strong articulation known as a kymphosis. A layer of cementum covers the dentin of the root. Cementum protects and firmly anchors the periodontal ligament. Cementum is histologically similar to bone and is less resistant to erosion than is dentin. The neck of the tooth marks the boundary between the root and the crown, the exposed portion of the tooth that projects beyond the soft tissue of the gingiva. A shallow groove called the gingival sulcus surrounds the neck of each tooth. The mucosa of the gingival sulcus is very thin and is not tightly bound to the periosteum. The epithelium is bound to the tooth at the base of the sulcus. This epithelial attachment prevents bacterial access to the lamina propria of the gingiva and the relatively soft cementum of the root. When you brush and massage your gums, you stimulate the epithelial cells and strengthen the attachment. A condition called gingivitis, or an inflation of the gingivae caused by bacterial infection, can occur if the attachment breaks down. A layer of enamel covers the dentin of the crown. Enamel, which contains calcium phosphate in a crystalline form, is the hardest biologically manufactured substance. Adequate amounts of calcium, phosphates, and vitamin D3 during childhood are essential if the enamel coating is to be completed and resistant to decay. Tooth decay generally results from the action of bacteria that live in your mouth. Bacteria adhering to the surfaces of the teeth produce a sticky matrix that traps food particles and creates deposits known as dental plaque. Over time, this organic material can become calcified, forming a hard layer of tartar or dental calculus, which can be difficult to remove. Tartar deposits most commonly develop at or near the gingival sulcus, where brushing cannot remove the soft plaque deposits. The alveolar processes of the maxillae and the mandible form the maxillary and mandibular arcades, or upper and lower dental arches respectively. These arcades contain 4 types of teeth, each with specific functions. One are the incisors, are blade-shaped teeth located at the front of the mouth. Incisors are useful for clipping or cutting, as when you nip off the tip of a carrot stick. These teeth have a single root. The cuspids, or canines, are conical, with a sharp ridgeline and a pointed tip, also known as eye teeth because they lie directly under the eye. The cuspids are used for tearing or slashing. You might weaken a tough piece of celery using the clipping action of the incisors and then take advantage of the shearing action of the cuspids. Cuspids have a single root. Bicuspids, or premolars, have a flattened crowns with prominent ridges. They crush, mash, and grind. Bicuspids have 1 or 2 roots. And 4, molars have very large, flattened crowns with prominent ridges adapted for crushing and grinding. You can usually shift a tough nut to your bicuspids and molars for successful crunching. Molars in the upper jaw typically have 3 roots, while those in the lower jaw usually have 2 roots. 2 sets of teeth form during development. The first to appear are the deciduous teeth, the temporary teeth of the primary dentition. Deciduous teeth are also called primary teeth, milk teeth, or baby teeth. Most children have 20 deciduous teeth. On each side of the upper and lower jaw, the primary dentition consists of 2 incisors, 1 cuspid, and a pair of deciduous molars. These teeth are later replaced by the secondary dentition, or permanent dentition, of the larger adult jaw. 3 additional molars appear on each side of the upper jaw and lower jaws as the person ages. These molars extend the rows of teeth posteriorly and bring the permanent tooth count to 32. As replacement proceeds, the periodontal ligaments and the roots of the primary teeth erode. The deciduous teeth either fall out or are pushed aside by the eruption or the emergence of secondary teeth. The adult premolars take place of the deciduous molars. The adult molars extend the tooth rows as the jaw enlarges. The third molars, or the wisdom teeth, may not erupt before age 21. Wisdom teeth may not erupt because they developed in inappropriate positions or because there's not enough space. Any teeth that develop in locations that do not allow them to erupt are called impacted teeth. Impacted wisdom teeth can be surgically removed to prevent the formation of abscesses. The muscles of mastication close your jaws and slide or rock your lower jaw from side to side. Chewing is not a simple process. It can involve any combination of mandibular elevation, depression, protraction, retraction, and medial or lateral movements. Try classifying these movements involved, and the next time you eat, you'll see how many there actually are. During mastication, you force food from the oral cavity to the vestibule and back, crossing and recrossing the occlusal surfaces. This movement resulting in part of the action from the muscles of mastication. Control would be impossible, however, without the help of the muscles of the cheek, lips, and tongue. Once you have shredded or turned the food to a satisfactory consistency and moistened it with salivary secretions, your tongue compacts the debris into a moist, cohesive bolus that is fairly easy to swallow.